Okay, maybe we should get a start. It's 5:05. So welcome, everyone. Today we have Ramona Sultana from Norfolk Norwich University Hospital. So Ramona is a radionuclide radiologist with a special interest in neuroradiology. Locally at Norfolk and Norwich, she chairs the skin and the hematology MDTs, the imaging, and currently is the clinical research expert for the department and the service lead in nuclear medicine. And today she's going to talk to us about melanoma. And Ramona, as Fiona was saying, maybe you would just say a few words about yourself and where you work before you start.
So as you said, I'm a consultant at Norwich. I have trained in Norwich. So I was part of the cohort from 2015. And then I did my training. Well, I did some PET reporting in Mount Vernon during my ST4, Mount Vernon Hospital in London. And then I did my ST5 training in Norwich, and then I stayed there as a consultant. So I've been a consultant for over 2 years now. Since then, I've also got a special interest in neuroradiology. So I'm hoping that in the next few months, I'm going to start dementia PET in Norwich, because we have a very large elderly population, but just not the elder, but like we have a very large dementia population. So we really need service. And I have recently took on the role of lead for nuclear medicine and PET, which hasn't been the most easy role because we have converted our analog PET scanner into digital. So we ended up having a mobile scanner until the update went through, which was for over 3 months. Now the digital PET is in and we are using it, but we want to build more uptake room. So it has been a challenge. And as you said, I am the clinical research expert for the trials that we have ongoing on PET, which at the moment are close to 30. So we do quite a bit of research as well. Okay, so I can share my screen and then we'll have a start. Okay, so this presentation was meant to be done by my colleague Claire Beesmore, who's currently our chief of imaging as well. But she's currently on annual leave, so she asked me to step in. I've done some changes to it because it's difficult to present from a presentation which you haven't prepared yourself. So the topic to be discussed today is melanoma and PET-CT. And I'm going to do a short introduction, then explain how immunotherapy works. Then we're going to go through some immune-related adverse events, which is actually the bulk of the talk today. And then I'm going to take you through some cases. So melanoma, it is the 5th commonest cancer in the world. In the UK alone, in 2018, we had close to 18,000 cases with 2,700 deaths. And globally in 2018, we had close to 288,000 cases with over 60,000 deaths. And the WHO predicts that by 2040, in the UK, we'll have close to 23,000 cases and 4,000 deaths, because there is a predicted rise in incidence of 13%. Why is there this rise in incidence in melanoma? So most people, they recognize that sun exposure is dangerous to the skin, but only 18% always protect their skin.
Sorry to interrupt, Ramona. I think your slides aren't changing.
Oh, yes. Okay, yeah. No, I didn't realize. So why is there this increase in incidence over the years in melanoma? So most people recognize that sun exposure is dangerous, but only 18% always protect their skin. Quite a few people believe that a tan is attractive. More people, which is I didn't know this before I prepared this presentation, but more people develop skin cancer from indoor tanning than lung cancer from smoking. And only 11% have their moles checked regularly by a dermatologist. And it is recommended that every 4 weeks we check our skin, and only 33% admit that they check their skin regularly. So understanding melanoma staging, so we do it using the TNM scale, similar to other tumor stagings. For tumor size, we use the Breslow depth, okay? And TIS is melanoma in situ, and it has the best 5-year survival, close to 100%. The other stages, the smaller the tumor size at diagnosis, the more favorable the outcome, which is expected, and it's similar to other tumors. When it comes to lymph node involvement, in addition to lymph nodes, we also need to consider in transit metastases, satellite metastases, and microsatellite metastases. And then M0 and M1, they are similar to other tumors. So there is quite a, so here when it comes to the 5-year survival on this paper, they quoted 50% for stage 4 melanoma. And then this paper quoted 22% for stage 4 melanoma. So there is quite a large discrepancy. And the reason for that is melanoma treatments have significantly improved lately because of the addition of immunotherapy and targeted therapy. And it is only now that we are starting to see, the numbers are starting to reflect these advancements. So I suspect that 22%, it's quite, how do you say, like the number is lower than reality. So immunotherapy, why do we use immunotherapy? So it's specific. The immune system has memory, so treatment will produce a sustained response. And how does immunotherapy work? So I'm going to take you how a T cell and cancer cell work. So cancer cells are very similar to normal cells. And T cells are patrolling, looking for invaders. And T cells, they are regulated by CD28, which are proteins on the outside that provide signals for T cell activation. And one of these is the PD-1. Some cancer cells have a PD-L1 ligand. And when the PD-L1 ligand from the cancer cell binds to the PD-1 receptor on the T cell lymphocyte, then the T cell lymphocyte is deactivated and the tumor is allowed to proliferate without further interference from the immune system. So now going to immune checkpoint inhibitors. So immune checkpoint inhibitors, they block this PD-1, PD-L1 binding, and therefore they block the off switch for the T cell lymphocyte. So this allows the T lymphocytes to recognize that this is a cancer cell, it's abnormal, and it leads to its destruction. Okay, and there are different types of immune checkpoint inhibitors. The PD-1 checkpoint inhibitors, commonly we use nivolumab and pembrolizumab, and the CTLA4 checkpoint inhibitors, so cytotoxic T lymphocyte associated ligand, associated antigen 4, commonly we use ipilimumab. Oh, I think that's why. Let me see. Because the one I'm sharing is not that one. Let me just share again. Okay. So there is a spectrum of activity of PD-1, PD-L1 blockade in advanced cancer, and it can be used over several types of cancer. So not just melanoma. So you can use it in renal cell, lung cancer, bladder, head and neck, squamous cell carcinomas, gastric tumors, lymphoma, ovarian, mesothelioma, liver, esophageal tumors. So a lot of tumors do expose this PD-L1 ligand, and then immunotherapy can be used as treatment. So currently the FDA approval for pembrolizumab is used. So pembrolizumab is an anti-PD-1 antibody, and that's used in melanoma, non-small cell lung cancer, and head and neck cancer. Nivolumab is licensed in melanoma, non-small cell lung cancer, renal cancer, and Hodgkin's, and atezolizumab is licensed in bladder cancer. Okay. And the effects of immunotherapy continue even if the patient has stopped immunotherapy, as you can see from this image. So if we consider a melanoma patient, so the blue line is when the patient is ongoing therapy, and the white dot is when the patient started to respond to treatment. But once they stop the immunotherapy, there is still a period of time where the patient is responding to treatment, is responding to immunotherapy, but they have stopped taking immunotherapy, okay? Because T cells, they are a type of they show adaptive immunity, so they will remember that these are tumor cells and they need to remove them. Okay. The downside of immunotherapy is its side effects, okay? So it is important for radiologists to be aware of immune-related adverse events. Many of these are asymptomatic because the patient wouldn't have started treatment on their first PETs, as when we do the baseline, and then you see an immune-related adverse event on the subsequent PETs. It is very easy to mistake this uptake for new metastatic lesions. Okay, and with such misinterpretation, then you can end up, the clinician may end up discontinuing the drug because they are worried that this is disease progression. So I quite like this picture because it gives a detailed overview of all the immune-related events caused by checkpoint inhibitors. But it is very detailed, so I'm going to go through some of the commonest ones in the presentation. So quite a few patients develop immune-related adverse events. Up to 95% of patients will develop at least one, and then like there will be people who will develop quite a few of these, and they may need termination of the immunotherapy. So the commonest side effect of immunotherapy is dermatological side effects, and obviously these are not radiologically detectable, and they can occur in up to 60% of patients. And these include hyperkeratosis, photosensitivity reactions, psoriasis, vitiligo, paniculitis, as you can see in these images. But PET plays a role in diagnosing these other adverse events that I'm going to discuss. So gastrointestinal complications, they are the second most common complication from immunotherapy, and these include mouth ulcers, esophagitis, gastritis, diarrhea, colitis. Diarrhea needs to be distinguished from colitis. Okay, so diarrhea, it implies only an increase in the frequency of stools, whereas colitis, it implies colonic inflammation. Mild to moderate diarrhea tends to resolve with steroid therapy, okay? and only 5% of patients with diarrhea secondary to immunotherapy will have CT evidence of a thickened colonic wall, suggesting that in most cases of clinically evident enterocolitis, the bowel will still appear normal on images. So this is a whole body map, as you can see, and this patient has got diffuse colitis. There is quite diffuse FDG uptake within the large bowel. And then these are the axial hybrid images and the axial PET and the axial CT images, and you can see that there is bowel wall thickening. So there are two types of immunotherapy associated colitis. The most common one is what we see here, which is diffuse colitis and mild bowel wall thickening. And on CT, then you can see, this is only one slide, so it's difficult to comment on this, but you can commonly see mesenteric vessel engorgement and fluid-filled colonic distension. The second type of immunotherapy-associated colitis is segmental colitis, and usually this occurs in an area of pre-existing diverticulosis. Endocrine side effects from immunotherapy, we see these quite frequently as well. Okay, so I'm going to speak about some, I've got further images to show you later on. So for example, hypophysitis, as you can see here. So we've got the PET, sorry, the CT, the PET and the hybrid, and you can see uptake within the pituitary fossa on the PET. So it is abnormal to see uptake in the pituitary fossa. So in that, once I see it, then I check whether the patient is on immunotherapy because they would have developed hypophysitis. Hypophysitis induced by immunotherapy, it occurs in about 5% of patients. And these patients will develop headaches, fatigue, visual field changes, and then there's hypothyroidism, hypogonadism, low cortisol, all secondary to the hypophysitis. If you do an MRI, it will demonstrate moderate enlargement of the pituitary gland, and after you start steroids, that enlargement will resolve. It will shrink to normal size within a few days on MRI, but the clinically, it will take much longer for the patient to recover from hypopituitarism, and they may never recover fully. This is an example of parotid inflammation. So CT, PET, and hybrid, and you can see there is diffuse uptake within the parotid glands, also because it's just because of inflammation secondary to immunotherapy, and this is very commonly seen. And another common complication is diffuse uptake within the thyroid gland due to thyroiditis. Thyroiditis from immunotherapy, it tends to be caused by infiltration of T lymphocytes within the thyroid gland. And if you do an ultrasound on these patients, it will appear similarly to Hashimoto thyroiditis. And unfortunately, most patients, they don't recover their thyroid function fully as well. Another side effect, this time not very common, is pneumonitis, and this occurs in less than 1% of patients receiving immunotherapy. And you can see like this kind of like diffuse consolidation and ground glass changes within the lungs. But once you stop immunotherapy, the patient, and with steroids, the patient starts to improve quite quickly. So cardiac toxicity can occur as well with immunotherapy. So in this case, we're showing a case of myocarditis. Thankfully, cardiac toxicity is quite rare, but it can be fatal. And the most common commonly reported toxicities include conduction disorders, so heart block, arrhythmias, or the patient can develop cardiomyopathy, heart failure, or is in this case myocarditis. Rheumatological toxicity secondary to immunotherapy. The patient can develop myositis, so inflammation within the muscles. And it is becoming increasingly recognized as a side effect. And the patients tend to present with rapidly progressive muscle weakness and elevated muscle enzymes. Okay. This is another case of myositis. So you can see like uptake within the gluteus maximus muscles here on the PET and the hybrid imaging. And as we said, an inflammatory arthropathy is also a side effect of immunotherapy. So this patient, they have uptake within the muscle secondary to myositis. This focus of uptake in the left antecubital fossa, there's just the injection site, so that's nothing to worry about. But they have uptake within the left glenohumeral joint and both knee joints, and that would be secondary to an inflammatory arthropathy secondary to immunotherapy. Apart from like an oligoarthritis picture, some patients can also develop polymyalgia rheumatica. Another immune-related adverse event can be fat necrosis, which can be quite difficult to diagnose on imaging because it is very easy to mistake this for a subcutaneous tissue metastases. But the patient can also develop fat necrosis anywhere, even in the breast. So this is a case of fat necrosis in the breast. Commonly, most PET reporters will notice, so commonly a sarcoid-like reaction post-immunotherapy. It can happen. So this image is showing the baseline PET, the first PET after immunotherapy, the second and the third. And as you can see, as soon as the patient started immunotherapy, there is this intense uptake within the mediastinal and bilateral hilar nodes. Okay, it can be a challenge to distinguish between reactive lymph nodes and nodal metastases because they both tend to accumulate a quite a significant amount of tracer, and you're going to see lymph node enlargement. So if there is doubt, it is best to obtain histology. Lesser common toxicities, which I'm not going to go into much detail, include renal, pancreatic, and neurological immune toxicities. Renal toxicity is often asymptomatic, and that's usually detected because of an increase in serum creatinine. Okay, and usually the investigation of choice, and imaging like wouldn't really help with renal toxicity. Cardiac, we've been through that already. Pancreatic toxicity is rare, but patients or on immunotherapy will have routine monitoring of amylase and lipase. Oh, sorry. Pancreatic toxicity is rare, so usually routine monitoring of amylase and lipase is not recommended. Okay, and the patients can have asymptomatic mild elevations of these enzymes, and if they are asymptomatic and the elevations are very mild, they shouldn't be treated. Okay, because then it resolves on its own. Neurological toxicities, they can be very non-specific and starting from fatigue and headaches, but you can get rarer toxicity, rare complications, including Guillain-Barré syndrome or central or peripheral neuropathies, transverse myelitis, myasthenia gravis, and encephalitis as side effects of immunotherapy, but thankfully these are quite rare. The time of onset of adverse events post immunotherapy varies. Okay, so most patients will develop skin symptoms, skin toxicity within 2 to 3 weeks, and then followed by gastrointestinal toxicity and hepatic toxicity within 6 to 7 weeks, and then endocrine and renal toxicity after 9 to 10 weeks of treatment. However, there is a positive association between having developed immune-related adverse events and responding to treatment. So this paper is a meta-analysis of 30 studies. So they had a total of close to 5,000 patients. And patients who were on PD-1 inhibitors, they found this association that if the patient developed a immune-related adverse event, particularly endocrine and dermatological, this showed a favorable benefit on survival. However, the reason for this is not really known. So I'm going to go through some cases. So this was meant to be a face-to-face talk, but due to works in the room, it had to be an online event. So I'm going to take you through the cases myself, and then I will show you the answers, obviously. So case 1, so patient 1, these are all melanoma cases. Okay, so I'm showing you the whole body MIP baseline and the first MIP post pembrolizumab. So when we look at the first whole body MIP, this patient had left groin nodal metastases. And then they started immunotherapy. And now looking at the left groin, those metastases have resolved. But then looking into more detail, there is uptake, diffuse uptake in the thyroid gland. So the patient developed thyroiditis. There is uptake within the muscles of the forearms and muscles of the thighs. So the patient has got myositis. This patient was difficult to cannulate. So this is the cannula side. So this is just a partially tissued cannula in the right upper arm. So don't in the right arm. So don't worry about that. And also this patient developed uptake within the pituitary fossa. So uptake in the pituitary fossa, uptake in the muscles, and uptake in the thyroid gland. And the left inguinal lymph nodes have resolved. So what's the result of this PET? And these are the choice to go through. And because the left groin nodes have resolved, the patient had a complete metabolic response. But because of the thyroiditis, hypophysitis, and myositis, the patient had immune-related adverse events. Okay, so I'm going to take you through the second patient who had a lung lesion, so in the right lung. That's the baseline PET, and this is the post-pembrolizumab PET. The lung lesion, you can still, it is more difficult to see, but you can still see it there, but there is no uptake in this location, so it has responded to treatment. But then looking below the diaphragm, there is this linear uptake within the biliary tree. And there is, this is just one slide, but there is quite intense uptake at the splenic flexure. So again, these are the same images from before. So what do we think happened in this case? So this patient had a lung lesion, which is not metabolically active anymore. So he's had a complete response to treatment. He's got linear uptake within the biliary tree. So he's got biliary tree inflammation, and he's got uptake with mural thickening at the splenic flexure. So he's got colitis. So patient had a complete metabolic response to treatment and had immune-related adverse events. Third patient. So baseline scan on the left. So I know this appears to be projected over the heart, but this was a lung metastasis, okay? So patient had a lung metastasis, had a large uterine mass, and had retroperitoneal metastases and had soft tissue deposits, as you can see here. And then the post pembrolizumab PET, the lung metastases has resolved. The subcutaneous tissue metastases that we see here have resolved. The uterine mass has reduced in size and avidity, so it has responded to treatment, but it hasn't gone completely. And then there is uptake here, which I'll show you the axials because it's much easier to see on the axials. So there's the gallbladder. So there is uptake within the gallbladder. And there is uptake within the large joints. So within both glenohumeral and both hip joints. So what do we think is the result of this? So the patient had a partial metabolic response to treatment because the uterine mass responded, but it hasn't completely resolved. And there is an immune-related adverse event because there is an inflammatory arthropathy and cholecystitis. Okay. Patient 4. So again, melanoma patient with lung metastases, as you can see here, liver metastases, and I'll show you the axials because it's a bit easier. So as you can see, lung metastases, liver metastases, and there's a metastatic deposit here within the gallbladder. Patient had pembrolizumab, and you can already see on the MIP that things didn't really go as planned. So within the lungs, there are multiple new lesions. If we have a look on the MIP, there are new cervical nodes, there's new axillary lymph nodes, there's a new subcutaneous tissue deposit in the right thigh. And the gallbladder metastasis, which is this, is much bigger. And there's also a new retroperitoneal metastases. So the result of this would be consistent. So they've had one PET post-treatment, so this would have been reported as progressive disease. Then they kept having immunotherapy and came back for a second PET. Actually, it will be the third PET from baseline, so they came back for a follow-up PET. And this is so this is the one that we've just seen. And so the first one, the second PET after starting immunotherapy, and the third PET. And we can see the disease has progressed. So there are much more lung nodules, and the gallbladder metastases has increased further in size, and there is this new adrenal metastases. So overall, this would be consistent with progressive disease. So this is the last case that I'm going to show you. So this is a young patient with liver metastases here, and a right pelvic nodal metastases from melanoma. And as you can see on the axial, so a liver metastases and a right external iliac nodal metastases. And her PET after treatment, you can see that she's developed new subcutaneous tissue nodules. Her liver metastases have completely resolved. There's new peritoneal nodules, and the groin nodes, they are much larger. And this is her post-treatment PET. So the right groin nodes are much larger, and she's got left axillary and subcutaneous tissue nodules. So this would be reported as progressive disease. Patient is kept on immunotherapy, and she comes back for a follow-up PET. So that's her baseline, that's her PET after immunotherapy, and this is her latest PET after continuing immunotherapy. And as you can see, the axillary and subcutaneous tissue lesions, they have resolved, and the right external iliac nodal mass is gone, and the peritoneal nodules, they're gone. This is uptake in the left antecubital fossa. That's where we've injected the tracer. She has developed left glenohumeral arthropathy and knee arthropathy. I've used this image earlier, and she's developed myositis within her forearm muscles. So she's responded now. So when we're looking at these scans in progression, she's now got a complete metabolic response. But what has happened in between the baseline and the post-treatment PET is that she had a flare response. So flare response, it will mimic disease progression. And as you all know, flare is because there is an increase in lesion size related to treatment. And basically, we also call it pseudo progression. And in about 60% of cases, pseudo progression occurs mainly within the first 3 months after completing treatment. So we do try not to perform PET-CT within 3 months of recent therapy, but this may not always be the case. So it can be a real challenge for clinicians because radiologically we cannot really distinguish between pseudo progression and true progression. And we can only do this on follow-up imaging. So nowadays, confirmation of progression needs to be on 2 consecutive scans, at least 4 weeks apart, to exclude a flare response. Okay, so it's flare response, and that's it. That's my presentation for today.